I'm going to start things off by talking a little bit about the new cancer care standards and specifically about distress screening. I'm going to then talk a little bit about why it's important to assess distress, and then also talk about some ways of assessing distress that you can actually bring to your centers if you're having a difficult time meeting the standards. And then we'll talk a little bit about what to do with distress and also with symptom management. So to start out with, cancer survivors, as probably everybody knows, number about 14 million in the United States today. And of those 14 million cancer survivors, almost 3 million of those are breast cancer survivors. So we know that approximately 1 in 8 women will develop breast cancer over the course of their lives. And in fact, cancer survivors actually comprise approximately 4% of the entire United States population. Now, the really good news is that due to the incredible advances in medical treatment over the past 30 to 40 years, about 65% of people who are diagnosed with cancer today can expect to live greater than 5 years after their diagnosis. And in fact, a full 15% of cancer survivors are now greater than 20-year survivors of cancer. So these are incredible advances in the care of people with cancer, but unfortunately, even the basic needs for psychosocial and supportive care remain unmet in most cancer centers across the country. So this is really important because we know that psychosocial distress is very prevalent in cancer patients and in breast cancer patients in particular. So we know that from at least these 2 studies that I've cited here that have measured distress in thousands of cancer patients, we know that there are significantly elevated levels of distress in cancer patients. We also know that when we're talking specifically about breast cancer, patients with breast cancer are also more likely to experience distress, not only compared to the general population, but also when you compare them to people who are diagnosed with benign breast disease. And I should mention also that this distress can actually occur at any time during the whole trajectory of cancer, including the period of survivorship after active treatment has ended. And so a lot of times we will see people who made it through cancer treatment just fine, but when we see them at their follow-up appointments, that's when they start to experience some of the distress, some of the depression, some of the anxiety about disease recurrence, and so forth that we hadn't seen before. And so this distress by no means ends when cancer treatment ends. Now, the most obvious consequence of high levels of distress are that it impairs quality of life. So people just aren't enjoying their day-to-day activities as much. They may not be interacting with their family and friends as much. They're not engaging in their normal hobbies. But there are also downstream effects of distress as well. So we know that people who are experiencing significantly high levels of distress may not function as well at work. They may be more prone to taking time off at work, and they're just not on their game at work. And so they may actually end up losing jobs, which can cause a lot of financial distress. We also know, very relevant to their cancer care, people with high levels of distress are less compliant with their medical care. So they may end up stopping medication without telling their treatment team. They may not show up for appointments with their physicians and their nurse teams. And this then can lead to increased medical costs because these people are more likely to show up to the emergency room. They're more likely to have inpatient admissions that weren't planned. And so the medical costs can again become very burdensome. And finally, we know that people who have high levels of distress simply don't take as good a care of their health. And so they are more likely to use substances excessively. They're more likely to smoke. They're more likely to even not engage in just basic things like putting on sunscreen, driving safely, and so forth. And so, again, all these things total up to a really high price tag, both psychosocially and also financially, for people who are distressed. So we've known this for some time, and the IOM in 2007 came out with a really great paper that was called Cancer Care for the Whole Patient, Meeting Psychosocial Health Needs. If you get a chance to read it, it's a really great paper, and it really started the ball rolling in terms of distress screening and really paying close attention to managing symptoms in our patients over time. And the crux of this article is that they basically concluded that all of the incredible advances that have occurred in biomedical care for cancer simply had not been matched by achievements in providing high-quality care for the psychosocial effects of cancer. And so this was really the first time that anyone had suggested that psychosocial care should not be an optional service for our patients, but it should actually be standard of care in the same way that, that medical treatments are considered standard of care. And this was really kind of the beginning of a real sea change in this area. One of the unfortunate things that we also know is that healthcare providers do a pretty terrible job of estimating or guessing at our patients' psychosocial distress. And this slide says physicians, in no means trying to call out physicians. These are just the 3 studies that I cite here looked at physicians, but there are plenty of studies that have looked at how nurses estimate patients' psychosocial distress, and I know of at least 2 studies that looked at psychologists and social workers' ability to estimate patients' distress, and pretty much to a study they have found that we are terrible at it. So it's really important to actually ask the patient directly. And as a side note, it's also interesting to note that the family members, even spouses and first-degree relatives of patients, also do a pretty terrible job of guessing at patients' distress. But interestingly, family members and caregivers tend to do it in the opposite way that we do it as healthcare providers. So they actually overestimate oncology patients' distress. And so all this really speaks to the need to go directly to the patient and to utilize patient-reported outcomes, basically just asking the patient directly, how distressed are you? Unfortunately, a lot of ASCO members, as this survey that I cite here found, there's not a lot of centers that actually routinely screen all patients for distress. And if you ask patients, why aren't you reporting distress, you'll hear a variety of different answers for that, and some of you have probably heard some of these answers. The biggest one that I hear is patients saying, I don't want to report my distress because I'm worried that my treatment will either be withheld or my chemo dose will be reduced, and I want to get my cancer treated as aggressively as possible. You'll also hear patients say things like, I can handle the fatigue, I can handle the depression, I can handle the pain. I don't want to distract my nurses and my doctors from a laser focus on curing my cancer. I can handle all this outside stuff. And so patients simply don't report distress and when they're very symptomatic to their healthcare team a lot. Now, if you ask physicians and nurses, why aren't you asking patients about their distress? And oftentimes what you'll hear is, well, I am this person's primary healthcare provider right now. I'm the most important healthcare provider in their lives at this moment. So if they're distressed or if they're experiencing pain or any number of other symptoms, of course they're going to come to me first. Who else would they go to? And that makes sense intuitively, right? But unfortunately, we know from the research that it just doesn't happen. And so that conversation between the healthcare team and the patient just never occurs a lot of times. So after the IOM report, the NCCN then got on board and came out with this statement that said that distress should be recognized, monitored, documented, and also treated promptly. Unfortunately, we know that even in NCCN institutions, so institutions that are really supposed to be the cream of the crop in terms of cancer care, we know that not all NCCN institutions are screening for distress. So just a couple years ago, a survey of all NCCN institutions was performed and found that only 70% of these institutions conducted routine screening for distress. And also disturbingly, of that 70%, only 50% of that group were screening all outpatients in their cancer clinics. The other 50% were only screening select subgroups. Now, there's a little bit of good news about this. pretty much the same survey was done 7 years earlier in 2005, and at that point, it was significantly fewer institutions that were routinely screening for distress. So there was over a 10% increase in routine screening among outpatients in that interim 7-year period. And the really good news is that there was a 23% increase in centers that were using patient self-report measures compared to 2005. So after the NCCN came out with this statement, then that led to the American College of Surgeons Commission on Cancer coming out with this new standard that took effect, as you're probably all aware, in January of 2015. And what this standard says is that the Cancer Committee is basically tasked with coming up with some sort of a process to monitor and assess psychosocial distress screening, and then the maybe even harder part, then you have to do something with it. So you either have to treat that distress on site, or you have to come up with a system to refer to community resources to take care of that distress. So this is one way of screening for distress, probably not the best way. So I'll tell you a few other ways that have been validated and replicated that are used to identify distress. These are the 4 probably most common screening tools: the NCCN Distress Thermometer, an instrument called the PHQ-9, the Hospital Anxiety and Depression Scale, and the Brief Symptom Inventory. It's an 18-item self-report measure. These are all patient self-report, again, meaning that you ask the patient directly. Their family member's not filling this form out for them. Healthcare providers are not filling out this form for them. The patient themselves are supposed to fill out this form. So you might also ask the question, does distress screening actually work? So if we're actually doing this the way that the College of Surgeons and the NCCN mandate, does this actually lead to any improvement in quality of life or in any clinical outcomes? And this study that was published in JCO in 2010 was the very first time that patients were randomly assigned to a distress screener or to something closer to standard of care. So there were over 1,000 patients, about half of whom had breast cancer and about half of whom had lung cancer, and they were randomized to one of 3 conditions. There was a minimal screening group, and what that meant was patients were given the NCCN Distress Thermometer, and then that was placed in their medical record, and the medical team was supposed to follow up with that. So basically kind of standard of care. The second group was what was called a full screening group, and that basically did the NCCN Distress Thermometer and then a couple of more depth distress screening instruments, and then an actual written summary was printed out and put in the patient's medical record. The third group got the full screening plus an actual printed out report that summarized the results. That was then placed in their medical record. A copy of it was also given to the patients, and then a nurse case manager actually reached out to those patients who scored above a certain threshold for distress to see if they could refer them to resources in the community. So they then measured these people at 3 months after the screening, and they found that indeed the full screening plus triage patients had significantly lower distress at 3 months after that initial distress screener compared to those who had the minimal screening or standard of care. So this was really the first study that said, yes, it's not only important that we measure distress, but if we do measure distress, it seems to have a positive impact on quality of life. So a lot of you are probably familiar with the NCCN Distress Thermometer. This is probably the most widely used distress screening tool. It's a good tool. It's easy to complete. It's very sort of user-friendly. It's very face valid. It's obvious what it's supposed to measure. The one problem with this is the distress thermometer does a fine job of measuring depression. It doesn't do a great job of measuring anxiety, and so you may need to supplement this with another instrument if you really want to catch all the patients who are experiencing clinically significant depression and anxiety. This isn't the full screener, but if you can see on the left-hand side, it's an actual thermometer. Any of you who aren't familiar with it, patients are instructed to circle on a scale of 0 to 10 where their distress has fallen that day and for the week leading up to that clinic visit. And then on the right-hand side of the form, this is not the full form, but there's a checklist of about 40 items that cover practical problems like finances, childcare, transportation, family problems like marital strife, issues with children, emotional problems like depression, anxiety, spiritual or religious concerns, and then physical problems such as pain, fatigue, overall physical functioning. So what do we know about depression and also about fatigue among cancer survivors? So we know that there is a risk of both depression and fatigue during active treatment, but there's also a risk of a much longer-term risk that exists even 4 to 8 years following a person's cancer diagnosis. We know that people who are depressed have an increased likelihood that they will need to be hospitalized for psychiatric reasons, and also some studies have shown that they have a higher likelihood of being hospitalized for medical reasons. Somewhere in the neighborhood of about 13 to 25% of survivors have clinically significant symptoms, meaning that they actually meet the DSM diagnosis that psychologists and psychiatrists and social workers use to diagnose depression. Also, in women with breast cancer, approximately 1/3 report clinically significant fatigue, and what we know is that in women with breast cancer, depression is very highly correlated with fatigue, also with pain, and with sleep disturbance. And this can become a very circular problem where depression can lead to people not sleeping well, and then that can lead to people being increasingly fatigued. When people are fatigued, they're more likely to report pain, and that tends to get worse, and then that again impacts depression and sleep, and it goes round and round like that. We know that fatigue is the most prevalent cancer-related symptom and can occur in anywhere from about 60% to 90% of cancer patients, depending on the study that you look at. In addition to depression, we also know that anxiety is a really big problem. So this anxiety is generally related to, it's kind of a health anxiety, but what we're also seeing very frequently in our cancer patients who are treated aggressively is post-traumatic stress, the same that you see in soldiers that are returning from war. And when you think about it, it's really a pretty similar circumstance in that what occurs is that people are exposed to a life-threatening event, whether that's active combat or a potentially life-threatening diagnosis of cancer. They approach that in some way that's intended to fix that life-threatening problem, and then what they're left with is a lot of depression, sleep problems, flashbacks, that kind of thing. And so we know that anywhere from 10 to about 30% of survivors have really clinically significant diagnosable symptoms of an anxiety disorder. And in addition to that, another 20 to 30% report what we would call subclinical post-traumatic stress symptoms. So not enough to meet the full criteria for post-traumatic stress disorder, but enough that their quality of life, their day-to-day activities are affected. Now, this is important just in terms of quality of life, but another really alarming fact is that we know that the rates of suicide among adults with cancer are approximately doubled compared to the general U.S. population. This is also true in older adults. So there's at least this one study that looked at over 1,000 residents in New Jersey who were over 65 years of age and found that older adults who were diagnosed with cancer had, again, double the rate of suicide, completed suicide, of seniors who were not diagnosed with cancer. Now, important and specific to breast cancer, the good news is that women with breast cancer are at somewhat a higher rate of suicide, but not double. So the highest suicide rates are associated with being male, Caucasian, and older than 50 years old. There are also some diagnostic considerations, and the patients who are at highest risk for completing suicide are those with lung cancer, gastric cancers, and head and neck cancers, which I suppose isn't too surprising given the high symptom burden of both the cancer and the cancer treatment in those diseases. So a number of resources are available for providers to help implement distress screening in your center, no matter whether you're in an academic medical center, whether you're in a big city, whether you're in a rural private oncology clinic. These resources are available to all providers and can really assist with implementing distress screening at your center. One of the other things that I push all of the time with my patients. My patients get really sick and tired of hearing me say exercise, 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 but I do it anyway. And the reason is exercise is probably the most strongly supported behavioral intervention for a host of problems. It's wonderful for fatigue, it's wonderful for pain, it's wonderful for overall physical functioning. Some studies have found that it's equal in terms of effectiveness to psychotherapy and medications for depression and anxiety. And so exercise is really one of the only sort of one-size-fits-all fixes for a lot of these problems that show up on distress screening. I have to thank my wife and my dog for this photo, by the way, so photo credit where it's due. The other thing related to exercise is a lot of patients will ask me, what exercise should I do? And the truth of the matter is, it doesn't really seem to matter much. If you do a PubMed search of exercise and cancer, you will find all types of exercise. You will find studies that have looked at Zumba, studies that have looked at using an Xbox and some of their exercise things, cycling, swimming, weight-bearing exercises, walking, yoga, Tai Chi. And almost all of those studies find a really significant impact of regular exercise. The reason I mentioned yoga on that previous slide is that two things. First of all, yoga is very modifiable based on a person's physical condition. So the poses that are done in yoga can easily be modified if someone is in a wheelchair, if someone has a more mild physical injury that they need to modify, if someone's feeling a lot of fatigue related to their cancer treatment. All of the poses are modifiable. So it's generally can be done by almost anyone who's going through cancer treatment or is a cancer survivor. The second reason is yoga also incorporates, in addition to the physical work, it also incorporates a lot of the deep breathing, the diaphragmatic breathing, and visual imagery that we use as therapists a lot of times to help people manage their anxiety. And so it really does kind of bridge that mind-body connection and can really impact people. And it's also, interestingly, one of the most widely studied interventions for women with breast cancer. And so it's really good in a breast cancer-specific population as well. So in terms of distress management, what do we actually do with it? So here at Northwestern, we're actually really fortunate in that we have a very broad supportive oncology team. So we can actually treat a lot of these distress-related symptoms ourselves, but that's definitely not the case if you are in a much more rural community where you may not have the same resources locally. And so I list all of these organizations because each one of these organizations, to some extent, has not only an in-person component, but also has the ability to provide telephone-based counseling, to have an internet presence. A lot of times these groups will have internet-based support groups or chat rooms that are monitored very closely, so patients can get a lot of support even online, even if they're in a very rural place and they can't necessarily make it to one of these cancer support communities.